Lymphoma. Both Hodgkin disease and non-Hodgkin lymphoma are important differential considerations for an anterior mediastinal mass. Lymphoma often presents as an aggressive, invasive mass. There is usually associated mediastinal lymphadenopathy which can be in the provascular or visceral compartments. In particular, internal mammary lymphadenopathy is very highly associated with mediastinal lymphomas. Calcification is rare in untreated lymphoma but common after treatment. Visceral compartment mediastinal mass. Adenopathy. Lymphadenopathy is an important cause of a middle mediastinal mass on radiography, etiologies of which include malignant and non-malignant causes. Lymph node calcification, low attenuation, and avid enhancement are unusual features for lymphoma. An alternative diagnosis should be considered if these imaging findings are seen. Eggshell calcification of lymph nodes is often present in silicosis and Cole-Worker's pneumoconiosis, less commonly in sarcoidosis. Given the greater prevalence of sarcoidosis, however, eggshell calcification may be seen more commonly in sarcoid overall. Dense calcification within a lymph node can be seen in sarcoidosis or as a sequela of prior granulomatous disease. Low attenuation lymph nodes, while nonspecific, should raise concern for active TB. Low attenuation lymph nodes can also be seen in fungal infections such as histoplasmosis, lymphoma, and metastatic disease. Hemorrhagic high attenuation lymph nodes can be seen in anthrax inhalation as part of hemorrhagic lymphadenitis and mediastinitis. Avid lymph node enhancement can be seen in Castleman disease, sarcoidosis, TB, and vascular metastasis. Avidly enhancing metastasis include renal cell carcinoma, thyroid carcinoma, lung carcinoma, sarcoma, melanoma. Castleman disease. Castleman disease, also known as angiofollicular lymph node hyperplasia, is a cause of highly vascular thoracic lymph node enlargement. The key imaging feature is avidly enhancing lymph nodes. Uncentric Castleman disease is seen as a single enlarged lymph node in children or young adults. Surgical resection is usually curative. Multicentric Castleman disease is almost always seen in patients with AIDS associated with HHV8. Multicentric disease often results in systemic illness including fever, anemia, and lymphoma. It is typically treated with chemotherapy. Epicardial fat pad. Epicardial fat infarct. Radiograph shows hazy opacity overlying the left heart border arrow. Axial CT image shows fat stranding and edema of the left epicardial fat pad in keeping with infarct. A prominent epicardial fat pad silhouettes the cardiac border on a frontal radiograph and may simulate cardiomegaly. Pericardial cyst. A pericardial cyst is a benign cystic lesion thought to be congenital. Most are located at the right cardiophrenic angle, between the heart and the diaphragm. Imaging shows a cystic lesion abutting the pericardium, which may change in shape on subsequent studies. Cardiac masses. Cardiac masses can be intracavitary, valvular, intramural, or epicardial pericardial. Composition of the mass, behavior at the margins, and enhancement characteristics are important diagnostic imaging features, as further discussed in the cardiac chapter. Thyroid lesion. Inferior extension of a goiter into the mediastinum. Chest radiograph demonstrates a right superior mediastinal mass arrow with obscuration of the superior border of the mass, representing the cervicothoracic sign, which implies that the mass is in continuity with the soft tissues of the neck. Non-contrast CT shows a large heterogeneous mass arrows with coarse calcifications replacing the thyroid gland. Although the thyroid is anterior, the goiter extends inferiorly into the middle mediastinum due to an embryologic fascial plane created by the inferior thyroidal artery. Case courtesy Ritu R. Gill, MD, MPH, Brigham and Women's Hospital. Benign and malignant thyroid masses may extend into the mediastinum, including goiter, thyroid neoplasm, and an enlarged gland due to thyroiditis. The key to diagnosis is to show continuity superiorly with the thyroid. Ascending aortic, aortic arch, or descending aortic aneurysm. An abnormality of the ascending aorta or aortic arch may appear as a mediastinal mass on radiography. Enlarged pulmonary artery, PA. An enlarged pulmonary artery, PA, can simulate a mass on a chest radiograph. As previously discussed, the hilum convergence sign can help distinguish between an enlarged PA and a mediastinal mass. The hilum convergence sign shows the peripheral pulmonary arteries converging into the mass, if the mass represents an enlarged pulmonary artery. Hiatal hernia. Hiatal hernia. Frontal radiograph shows a retrocardiac lucency arrows, which was confirmed to be a moderate-sized hiatal hernia on court arrows. A hiatal hernia is protrusion of a portion of the stomach through the esophageal hiatus. The esophageal hiatus is an elliptical opening in the diaphragm just to the left of midline. On radiography, air or an air fluid level is often present above the diaphragm. Morgagni hernia. Morgagni hernia is a diaphragmatic hernia through the foramen of Morgagni that occurs anteriorly where the two hemodiaphragms meet, containing omental fat and often bowel. The contents of a Morgagni hernia typically fall to the right. An anterior mediastinal mass in contact with the diaphragm containing bowel gas is diagnostic for a Morgagni hernia. If bowel gas is absent, a key to diagnosis on CT is the detection of omental vessels in the mass that can be traced into the upper abdomen. Esophageal neoplasm. A focal esophageal lesion is concerning for adenocarcinoma or squamous cell carcinoma. Esophageal carcinoma can present on radiography as abnormal convexity of the azygosophageal recess, mediastinal widening, or a retrotracheal mass. Benign mesenchymal esophageal tumors include fibrovascular polyp, leiomyoma, fibroma, or lipoma. Foregut duplication cyst. Foregut duplication cysts include bronchogenic cysts, esophageal duplication cysts, and neurenteric cysts. Although often low attenuation, internal heterogeneity can be due to hemorrhagic or proteinaceous components or superinfection. Bronchogenic cysts can arise from any mediastinal compartment, but they most commonly arise near the carina in the visceral compartment, typically in right paratracheal space, subcarinal space, or HeLa. The lesion's thin walls may enhance or have intrinsic calcifications. Esophageal duplication cysts are adjacent to the esophagus. Bronchogenic cyst. Frontal radiograph shows a subtle opacity overlying the right heart arrows, shown to be a fluid attenuation lesion adjacent to the esophagus on court. Case courtesy Daryl Sneeg, MD, Brigham and Women's Hospital. Paraganglioma. Cardiac or aortopulmonary paragangliomas can present as a visceral compartment mediastinal mass, arising from phrenic, vagus, and recurrent laryngeal nerves. A paraganglioma or extraadrenal pheochromocytoma is a highly vascular neuroendocrine tumor that originates from embryonic neural crest cells of the peripheral nervous system. It can be sympathetic or parasympathetic. A visceral compartment mediastinal paraganglioma tends to be parasympathetic in origin. Malignancy can occur in up to 10% of extraadrenal pheochromocytomas. They can be functioning or non-functioning. CT appearance is of a hypervascular mass with robust feeding arteries. There may be internal heterogeneity representing necrosis. MRI shows a T1 intermediate, T2 hyperintense mass with homogeneous enhancement. Contrast-enhanced axial CT shows a hypervascular mediastinal mass, yellow arrow, with central areas of necrosis, red arrow, directly abutating the borders of the ascending and descending thoracic aorta just above the level of the pulmonary veins, consistent with a parasympathetic paraganglioma. Paravertebral compartment mediastinal mass. Neurogenic tumor. A neurogenic tumor may arise from either a peripheral nerve or the sympathetic ganglia. Most adult tumors are peripheral nerve sheath tumors, and the vast majority of tumors in children are of sympathetic ganglionic origin. Overall, neurogenic tumors are the most common paravertebral compartment mediastinal masses. Imaging features typically show a smooth round mass. Benign pressure erosion of adjacent ribs, vertebrae, and enlargement of neuroforamina may occur. Interval growth of a neurogenic tumor with regions of internal heterogeneity should raise concern for transformation to malignant peripheral nerve sheath tumor. Peripheral nerve tumors, more common in adults, include schwannoma, most common, neurofibroma, and malignant peripheral nerve sheath tumor. Frontal radiograph. Lateral radiograph. Axial CT with contrast. Axial T2 weighted MRI. Schwannoma. Frontal radiograph shows a round opacity overlying the right hilum with the hilum overlay sign, arrow, corresponding to a paravertebral abnormality on lateral radiograph. CT shows a low-density lesion without significant enhancement. MRI shows heterogeneous T2 hyperintense signal within the cystic lesion in keeping with a schwannoma. Sympathetic ganglion tumors, more common in children, young adults, include ganglioneuroma, most common, a benign tumor of sympathetic ganglion cells. Neuroblastoma, a malignant tumor of ganglion cells seen in early childhood. Ganglioneuroblastoma, intermediate in histology between ganglioneuroma and neuroblastoma, seen in older children than neuroblastoma. Paragangliomas can arise in the paravertebral compartment from spinal, intercostal, or sympathetic nerves. Contrast-enhanced axial CT shows a paravertebral hypervascular mass with heterogeneous areas of necrosis, arrow, consistent with a paraganglioma along the sympathetic chain. Extramedullary hematopoiesis. Extramedullary hematopoiesis presents as soft tissue paravertebral masses in patients with severe hereditary anemias including thalassemia and sickle cell anemia. On imaging, lobulated soft tissue masses are typically bilateral and inferior to T6. They may contain internal fat. Intrathoracic meningocele. An intrathoracic or lateral meningocele is herniation of the leptomeninges through either an intervertebral foramen or a defect in the vertebral body. Lateral meningocele is associated with neurofibromatosis. Paraspinal abscess. Osteomyelitis and paraspinal phlegmon. Radiograph shows displacement of the bilateral paraspinal lines arrows. Sagittal T1 middle image and T2 weighted MRI right image shows loss of disc space height and marrow edema in two adjacent lower thoracic vertebral bodies. There is associated paraspinal phlegmonous change arrows which cause the paraspinal line displacement on radiography. A clue to vertebral body pathology on radiography may be paraspinal line displacement. Airways. Multifocal or diffuse non-neoplastic tracheal stenosis, wall thickening. Overview of non-neoplastic diffuse tracheal disease. Cartilage abnormalities of the ear or nose. Nodularly calci, number 1F, ed tracheal wall. Signs of endobronchial or parenchymal TB. Irregular thickening, plus or minus calci, number 1F cation. Subglottic tracheal thickening. Hilar or mediastinal adenopathy. Paralymphatic nodules. Multifocal or D, number 1F, use non-neoplastic tracheal thickening. Sparing of the posterior trachea. Circumferential thickening. Relapsing polychondritis. Relapsing polychondritis is a multisystemic disease of unknown etiology characterized by recurrent inflammation of cartilaginous structures. The nose, ear, joints, larynx, trachea, and bronchi can be affected, with airway involvement seen in 50% of patients. The larynx and subglottic trachea are the most common sites of airway involvement. Relapsing polychondritis usually occurs in middle-aged women. On cross-sectional imaging, there is smooth tracheal bronchial wall thickening, with sparing of the posterior membranous trachea. The tracheal cartilage is an incomplete ring, with no cartilage in the posterior membranous portion. There is often increased attenuation of the airway wall, ranging from subtly increased attenuation to frank calcification. Tracheomalacia, expiratory collapse of the trachea, is commonly present. Tracheobronchopathia osteochondroplastica (TPO). Tracheobronchopathia osteochondroplastica (TPO) is a benign condition of multiple submucosal osteocartilaginous nodules along the tracheal walls that appear as coarse calcifications, with sparing of the posterior membranous trachea. Tuberculosis. Tracheal tuberculosis. Axial CT in soft tissue window through the upper trachea, left image shows circumferential tracheal thickening arrows. Coronal curved multiplanar reformation, right image shows multifocal tracheal stenosis, arrows, and left mainstem bronchus stenosis. These images were obtained approximately 1 month after treatment for active post-primary TB. Case courtesy Ritu R. Gill, MD, MPH, Brigham and Women's Hospital. Airway involvement by TB occurs in a prominent minority of patients with pulmonary TB, most commonly involving the distal trachea and proximal bronchi. Imaging findings are nonspecific. There is usually smooth concentric narrowing of a relatively long airway segment, typically greater than 3 cm. Amyloidosis. Tracheal amyloid. Axial CT images show nodular and irregular thickening of the trachea arrows. This pattern is not specific, and the differential diagnosis would also include sarcoidosis, multifocal adenoid cystic carcinoma, and tracheal metastasis. Case courtesy Ritu R. Gill, MD, MPH, Brigham and Women's Hospital. Amyloidosis causes irregular narrowing of the airways due to submucosal amyloid deposition, which may be calcified. Involvement may be mass-like or segmental. Tracheal amyloidosis is very rare. The posterior membranous trachea is not spared. Granulomatosis with polyangiitis (GPA). Large airway involvement is seen in approximately 20% of patients with GPA, most commonly manifesting as subglottic tracheal stenosis with circumferential mucosal thickening. The posterior membranous trachea is not spared. Calcifications are not seen. Sarcoidosis. Tracheal involvement by sarcoid is rare and usually seen in advanced disease. Tracheal sarcoid has a variable appearance ranging from smooth stenosis to a nodular or mass-like appearance. The posterior membranous trachea is not spared. Large airways. Bronchiectasis. Bronchiectasis is progressive, irreversible dilation of cartilage-containing bronchi. 3 etiologies of bronchiectasis have been described: with a final common pathway of mucus plugging, superimposed bacterial colonization, and inflammatory response. Bronchial wall injury, typically from infection or inflammation. Bronchial lumen obstruction. Traction from adjacent fibrosis. Morphologic classification of bronchiectasis is most useful as a rough gauge of severity. Cylindrical bronchiectasis, least severe, mild bronchial dilation. Varicose bronchiectasis, moderately severe, bronchi may become beaded and irregular. Cystic bronchiectasis, most severe, bronchi are markedly enlarged and ballooned. Radiographic findings depend on severity. In mild cases only tram tracts may be visible, representing thickened bronchial walls causing parallel radiopaque lines resembling tram tracks. In more severe cases there can be extensive cystic change. CT findings include the signet ring sign, which describes a dilated bronchus adjacent to a normal pulmonary artery branch. Normally each bronchus should be approximately the same size as the adjacent pulmonary artery branch. Other CT findings of bronchiectasis include lack of bronchial tapering, bronchial wall thickening, and mucus-filled bronchi. Often, adjacent tree and bud nodules are present, likely representing associated small airways infection. Traction bronchiectasis occurs secondary to lung fibrosis, see earlier discussion of ILD. Patterns of primary bronchiectasis can be divided into lung zones and central to peripheral distribution. Upper lung, cystic fibrosis, ABPA. Mid-lung, atypical mycobacteria. Lower lung, chronic aspiration, post-infectious, immotile cilia, immunodeficiency. Central, ABPA, Monier-Kuhn, tracheobronchomegaly. Mid-order bronchi, Williams-Campbell, 4th to 6th order bronchi. Bronchiectasis, continued. Chronic aspiration is the most common cause of bronchiectasis. Bronchiectasis from chronic aspiration. Axial and coronal CT show bronchial wall thickening in the bilateral lower lobes due to dependent aspiration, arrows. Bronchocentric infections, such as tuberculosis and atypical mycobacteria. Bronchiectasis of the right middle lobe and lingula, arrows, due to Mycobacterium avium intracellular infection. Ineffective clearing of secretions, cystic fibrosis and Cartagner, primary ciliary dyskinesia. Bronchiectasis from cystic fibrosis with superimposed pneumonia. Radiograph shows upper lobe bronchiectasis with a focal left upper lobe opacity, yellow arrow. CT confirms bronchiectasis, red arrows, and a left upper lobe consolidation, yellow arrow, representing pneumonia. Congenital connective tissue disorders. Monier-Kuhn, a connective tissue disorder causing tracheobronchomegaly leading to recurrent pneumonia, or Williams-Campbell, a rare disorder of the 4th to 6th mid-order bronchial cartilage, which may be congenital or acquired as a sequela of viral infection. Monier-Kuhn. Chest radiograph, left image, shows severe diffuse bronchiectasis. CT shows tracheal dilation, calipers, up to 3 cm and severe cystic bronchiectasis. Broncholithesis. Broncholithesis is a rare disorder of calcified, ossified material within the bronchial lumen, caused by erosion of an adjacent calcified granulomatous lymph node. Broncholithesis clinically presents with nonproductive cough, hemoptysis, and air trapping. Focal non-neoplastic tracheal stenosis, wall thickening. Intubation, tracheostomy. There is approximately 1% risk of tracheal stenosis after intubation, but approximately 30% risk of stenosis after long-standing tracheostomy. Rare causes of focal tracheal stenosis. Extremely uncommon causes of focal tracheal stenosis include Behçet and Crohn disease. Airway tumors. Primary tumors of the trachea and central bronchi are rare. In adults, the vast majority of tumors are malignant, while in children most are benign. Squamous cell carcinoma and adenoid cystic carcinoma are by far the two most common primary central airway tumors in adults. Squamous cell carcinoma, SCC. Endotracheal squamous cell carcinoma. Radiograph shows a tracheoluminal narrowing, arrow, at the level of the thoracic inlet. On CT there is an eccentric enhancing mass invading the left tracheal wall and markedly narrowing the tracheal lumen, arrow. Squamous cell carcinoma is the most common primary tracheal malignancy. It is strongly associated with cigarette smoking. The typical CT appearance of tracheal squamous cell carcinoma is a polypoid intraluminal mass. The contours of the mass can be irregular, smooth, or lobulated. The tumor can occasionally invade into the esophagus, causing tracheoesophageal fistula. Adenoid cystic carcinoma, ACC. Tracheal adenoid cystic carcinoma. CT, left image, shows irregular circumferential tracheal thickening, arrow. Post-contrast coronal T1 weighted MRI, right image, shows an enhancing nodular mass extending into the tracheal lumen, arrows. Case courtesy Ritu R. Gill, MD, MPH, Brigham and Women's Hospital. Adenoid cystic carcinoma, ACC, is a relatively low-grade malignancy that usually affects patients in their 40s, a decade or two younger than the typical SCC patient. It is not associated with cigarette smoking. ACC has a propensity for perineural and submucosal spread. It may spread over a long segment of the trachea, complicating the ability to resect the lesion. The typical CT appearance of ACC is a submucosal mass that infiltrates the tracheal wall and surrounding mediastinal fat. ACC may also present as circumferential tracheal or bronchial thickening causing airway stenosis. Carcinoid. Endobronchial carcinoid. Chest radiograph shows right lower lobe atelectasis, arrows, and volume loss. Axial contrast enhanced CT shows a mildly enhancing well-circumscribed endobronchial mass, arrow, in the right mainstem bronchus just distal to the carina. Carcinoid almost always occurs distal to the carina. CT shows an endoluminal bronchial mass that may calcify and often enhances avidly. Note that carcinoid tumors tend to have a larger extrinsic component than endobronchial component. In addition to carcinoid, the differential diagnosis of an enhancing endobronchial mass includes mucoepidermoid carcinoma and very rare entities such as hemangioma and glomus tumor. Mucoepidermoid carcinoma. Mucoepidermoid carcinoma is a rare tumor that originates from tiny salivary glands lining the tracheobronchial tree. Mucoepidermoid carcinoma tends to affect younger patients than adenoid cystic carcinoma. CT appearance is a round or oval endobronchial mass, indistinguishable from carcinoid. Tracheal lymphoma. Tracheal lymphoma is rare. It is usually associated with mucosa-associated lymphoid tissue, MALT, a low-grade malignancy. Endobronchial metastasis. Endobronchial metastasis. Coronal contrast enhanced CT demonstrates a heterogeneously enhancing mass, which invades the right mainstem bronchus, arrows. This was a spindle cell carcinoma, but the imaging appearance is nonspecific. Breast cancer, renal cell carcinoma, thyroid cancer, lung cancer, melanoma, and sarcoma are the most common malignancies to metastasize to the central airways. The mnemonic breath lung may be helpful to remember the four most common airway metastasis: breast, renal cell, thyroid, and lung. Direct invasion of the central airways by adjacent malignancy. Direct central airway invasion occurs more commonly than endobronchial metastasis. Aggressive laryngeal, thyroid, esophageal, and lung cancer may cause direct airway invasion. Benign endobronchial lesions. Papilloma is a benign but potentially pre-malignant lesion that may transform into carcinoma. Suspected papillomas are typically closely followed. A single papilloma is usually caused by chronic irritation. Multiple papillomas, laryngotracheal papillomatosis, is caused by HPV, which may be acquired at birth. Distribution is usually centered in the larynx, with tracheobronchial involvement in 1–5% of cases. Papillomas may spread to the lungs, where they will form multiple cavitary nodules with dependent distribution. Chondroma is a benign cartilaginous tumor that rarely may occur in the airways. Other benign endobronchial lesions include schwannoma, adenoma, hamartoma, hemangioma, lipoma, and leiomyoma. Emphysema. Emphysema is the destruction of alveolar walls resulting in irreversible enlargement of the distal airspaces. Elastase is produced by alveolar macrophages and neutrophils, both of which are increased in smokers. Elastase is a powerful destructive enzyme which functions in the host defense mechanism, but excess elastase can be highly harmful to the native tissues. Alpha-1 antitrypsin normally neutralizes elastase. Either a surplus of elastase in smoking-related emphysema or insufficient neutralizing enzyme in alpha-1 antitrypsin deficiency can cause lung destruction and resultant emphysema. Centrilobular emphysema. Centrilobular and paraseptal emphysema. Coronal left image and axial CT demonstrates both centrilobular and paraseptal emphysema. Centrilobular emphysema is predominant in the upper lobes, yellow arrows, and paraseptal emphysema is seen anteromedially, blue arrows. Centrilobular emphysema is a smoking-related lung disease. Centrilobular emphysema predominantly affects the upper lobes. Like RBILD, another smoking-related lung disease, centrilobular emphysema primarily affects the center of the secondary pulmonary lobule. All smoking-related lung disease RB, RBILD, DIP, PLCH, and emphysema may be within the same spectrum of disease caused by macrophage-mediated inflammation in reaction to inhaled particles and toxins. Paraseptal emphysema. Paraseptal emphysema is usually seen in combination with other forms of emphysema. It is also usually smoking-related. Paraseptal emphysema is subpleural in location and may predispose to pneumothorax. Panasonar panlobular emphysema. Panasonar, also called panlobular emphysema, affects the entire acinus diffusely throughout the lung. The emphysematous changes are usually more severe at the lung bases. Alpha-1 antitrypsin deficiency is the main cause of panasonar emphysema. Panasonar emphysema due to alpha-1 antitrypsin deficiency. Frontal radiograph and coronal CT show diffuse emphysematous changes most severely affecting the lower lobes, with flattening of the diaphragm's arrows.